my screen.
يس يا دكتور، ممكن نعمل سلايد شو.
ما انا عامل سلايد شو اهو، بس اصلا انا عندي تو سكرينز فظهر على السكرين الثاني. انا مش عارف ليه ظهر
خلاص
على السكرين الثاني.
ايوه، ايوه السكرين دي بقى نعملها سلايد شو، معلش.
اعمل لها
سلايد شو.
سلايد شو يعني ايه؟
سلايد شو يا دكتور، وضع العرض.
يعني دي. طب ما هي اوريدي اهي دلوقتي، ما هي لما
اول واحده يا دكتور، ايوه اول واحده تمام.
اهي لما بعمل كده بتطلع على السكرين الثاني.
مم. خلاص مش مشكله، احنا شايفين كده برضه.
لا، ما انا ما عايزك هتبقى كبير عشان كل الناس تشوف.
طب تحت يا دكتور كده، تحت
آه.
على اليمين، ايوه.
تحت على اليمين في ايه؟
وضع السلايد شو ده.
اخلي اكبر
لا لا،
الصورة.
مش دي اللي جنبها، الزوم ده اللي جنبه. لا 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 لا. وضع، ايوه الرمز الشاشه اللي جنبه ده يا دكتور.
رمز الشاشة ده.
ايوه ده، بالظبط يا دكتور.
لايت شو. مش عايز، لان هو مبينها اوريدي على الناحية على السكرين الثاني. طب انا الغي واحد منهم ولا ايه؟
تمام يا ريت.
طب الغيه
يعني اقفل ويندو، اقف على باب بوينت من تحت هيطلع لك كل الويندوز المفتوحه. اقفل الزياده.
دي ماشي، واقفل دي. اقفل كل الويندوز الزيادة، ساين اوت. طيب ادي ده كمان بره. بعدين دلوقتي بقى انتوا لسه شايفيني مش كده؟
شايفين يا دكتور.
طيب اما نعمل سلايد شو تاني بقى. يعني راحت على السكرين الثانية. طب ابدا من اول تاني شير واغير السكرين، احاول
تمام.
طبعا. ماشي.
تمام يا دكتور.
نيو شير، نيو شير. اعمل نيو شير اهي. طيب هي دي ماشي. اعتقد ان انتوا كده شايفيني. اعتقد ان انتوا كده شايفيني.
احنا شايفين حضرتك يا دكتور.
مش
كده
كده؟
تمام زي الفل كده.
شايفين
كده ظبط كده.
السلايد شو كوريكت؟
بالظبط بالظبط كده
او كده ماشي. لما تحبوا تبداوا قولوا لي.
تمام احنا جاهزين يا دكتور، اهلا بحضرتك يعني.
طيب ماشي، بسم الله الرحمن الرحيم. We are going to have 3 MCQs and 3 cases to discuss. I like every and each one of you to be interactive and to respond to my questions. Okay. So question number 1. We have a 20-year-old mother. She's at 35 weeks of gestation, evaluated in the emergency department because she has 2-day history of nausea, vomiting, diarrhea, and body aches. Mom has some sort of infection which can affect the baby. She is worried because the ice cream brand she ate 2 weeks ago has been linked to listeria. Okay.
مساء الخير دكتور ايهاب، ازي حضرتك؟
الله يخليك. So we are going to talk about listeria. Initial assessment reveals maternal temperature of 38.9, and she started uterine contractions because listeria can induce preterm labor. The woman is admitted for intravenous antibiotic because the infection, of course, can affect the baby. And this baby is going to be preterm, so the sequelae could be more serious. So admitted for intravenous antibiotics and for the management of the preterm delivery. and with labor expected within 24 hours following admission. Okay. We have a sick mom. Most probably she's having listeria because of the history and clinical presentation. And she's pregnant at 35 weeks. Listeria caused early uterine contractions and is inducing preterm labor. And there is a possibility of the infection transmitted from the mother to the baby. And also the mom is symptomatic, needs treatment. So question is, of the following, what is the maternal treatment that is most likely to improve her neonate's severity of illness? Now we are talking about the baby. The labor and delivery guys are taking care of the mom, the mother, but we are talking about our baby. So, what is the best treatment that is going to see what is the key point here? Improve the neonate's severity of illness. So if this baby develops even infection, at least we need to, if we cannot prevent it, we can make it less severe. If we give intramuscular betamethasone to the mother or intravenous ampicillin to the mother, intravenous ceftriaxone, or intravenous magnesium sulfate. Okay, number one, why we should, what is the value of giving intramuscular betamethasone at this point? Yeah, I just need you to interact with me. Don't jump to the solution or to answer the question, because the question is not bad, but we need to make discussions. I know that every and each one of you choose B, intravenous ampicillin, but let us go with every option. Why intramuscular betamethasone? Does it have a place here? What is the value of giving intravenous betamethasone to a pregnant woman who is expected to have preterm labor? How does it help? Betamethasone, antenatal steroid with benefit. Decrease severity of RDS. Yes, this is number one. What else? Many benefits for preterm. I need to know what are those benefits, please. Decrease that, yes, it decreases the chance of getting neck, correct? What else? It improves lung maturity, yes. And usually it's given before the age of 34 weeks. So even if this baby had nothing but premature, or mother had nothing but premature delivery, she's not a good candidate for betamethasone, but it can increase maturity of the lung, decrease the severity of RDS, decrease the incidence or severity of neck. What else? It also decreases the severity and frequency of BPD. This is extremely important. And IVH, intraventricular hemorrhage. So maturation of the lung, it has good benefits for prevention of or decreasing the severity of neck, PPD, and IVH. But definitely it doesn't have a role in this scenario. I will jump to C, intravenous ceftriaxone. Does ceftriaxone play a role here for treating the mother and making the severity of illness in this preterm baby less, or improve the severity? Is it going to help? mature GIT, no, not take surfactant, improve kidney. No. This is all not related. This is not the correct answer to my question. Listeria is resistant to cephalosporin. This is the correct response to my question. Yes, ceftriaxone is not going to help the mother or the baby because Listeria is resistant to cephalosporins, including ceftriaxone, and we are going to go more in details with that. Intravenous magnesium. Why we give intravenous magnesium to a mother who is having impending or imminent preterm labor? It is, by the way, it is very important medication, and it is used a lot by the labor and delivery guys in the scenario of mom having preterm labor. What is the value of giving intravenous magnesium sulfate? Glucolysis, yes, it is given to prevent preterm labor and reduce uterine contractions, correct? Neuroprotective, yes. There was a very famous study done, included hundreds of babies where the magnesium sulfate was, hundreds of preterm babies, and was given to the mom, and it proved that it has very good neuroprotective function. But do we need it now for this baby, 35 weeker, and we have problem of listeria? It doesn't play a role here, maybe in other scenario. So we are left with option B, intravenous ampicillin. So listeria is sensitive to ampicillin. But when you give, you have a baby with a term or preterm, and your mom is giving you a classical history of listeria, or even the baby is symptomatic and having listeriosis, neonatal listeriosis. What antibiotics do you give? You just give ampicillin, and that's it? Do you like to add another antibiotic? Yes, we add gentamicin because there is a good synergism between the gentamicin and ampicillin in treating listeriosis, as we are going to see. Okay, so the answer is ampicillin. This is a febrile pregnant woman with exposure to listeria. It's associated with a reduction of incidence of severity of the neonatal listeriosis. This is the main role of ampicillin given to the mom. Okay, what if the mother is sensitive to ampicillin, is allergic? What is the second option? It is trimethoprim and sulfamethoxazole. If mom is having penicillin allergy. No, it is not rifampicin. Sorry. Cotrimazole is antifungal. It is not used to treat bacteria. Rifampicillin, no. Vancomycin, no. It is trimethoprim and sulfamethoxazole. Okay? And we see that it is resistant to all cephalosporins. Okay? The mother in the vignette has, most probably she has listeria monocytosis, monocytogenous infection. How can it present in the mom and in the baby? In the mother, pregnant mom, it may be asymptomatic, and this is most of the cases. Even if the baby is having clinical listeriosis, you might not find symptoms in the mother, but so it can present asymptomatic, or it can be as presenting as a non-specific prodromal febrile illness. And usually there is gastrointestinal problem. The mother had nausea, vomiting, and diarrhea. which goes very, very much with the presentation of listeria in the pregnant mother. Also, it can present with something very serious, which is acute chorioamnionitis. And chorioamnionitis is like a nightmare. Why? Why chorioamnionitis is not something friendly to the babies, especially the preterm ones? What are the sequelae if the mother is having untreated chorioamnionitis and you have a preterm baby? It is if you can make the opposite of antenatal steroids. Increase the incidence of NEC, of BPD, and IVH. And of course, it can cause sepsis, early or late onset sepsis. Nearly all cases of pregnancy-associated listeriosis that occur in the newborn occur in otherwise healthy women, as I told you. Usually the mom is asymptomatic, but luckily enough, mom had classical presentation. How can the listeria pass or affect the baby, whether before or during or after delivery? The listeria can go either transplacentally or another route, which is ascending infection, which happens during childbirth, during vaginal delivery. And mom is having listeria that can ascend through her genital tract and to the uterus to the baby. In more than 80% of cases of transmission, usually occurs in the third trimester. Usually in the third trimester. Okay, what are the effects of mom having listeriosis on the fetus and baby? Number one, fetal death. Number two, preterm birth, as we saw in this scenario. Early or late onset neonatal listeriosis infection. Correct? We cannot tell exactly what is the incidence of transmission because most of the cases are either non-specific manifestation or asymptomatic. I mean in the mother, okay? So how can you diagnose it? You have to isolate the bacteria from samples from the mother. And later on, if they have the baby, it will be the blood culture. From the mother, you can isolate it from the blood or the products of conception, like the placenta, if you do placental pathology, or from the baby, him or herself. And these are the guidelines of the American College of Obstetrics and Gynecology, which is beyond our scope of experience. I hope the guys in Alexandria are using some guidelines. One question, Dr. Marwa, are you with us?
حضرتك يا دكتور.
Okay, sir. ازيك يا دكتورة مروة? Do you see cases of listeriosis or you don't see it?
We suspected, but we didn't see, we didn't confirm presence of
I can tell you why many of cases of listeria in the baby maybe or in the mother may be missed by the blood culture, because they can be misdiagnosed as a diphtheroids, which are commensals. They are contaminant. They are not pathological bacteria. So if you suspect listeriosis in the mother or in the baby, in the pregnant mother or in the baby, you should talk to the lab and ask them specifically, please look for listeria, because if you don't say that, most of the time they will let you know, no, it's just diphtheroids, it's a contaminant, which gives you a false negative test, which can affect the health of both pregnant mother and the baby. So we talked for how long, for how many days you can give the baby antibiotics at least 14 hours. And if there is meningitis, you have to go to 21 days. Okay. Neonatal outcome is strongly associated with gestational age, and this is very logic. The more the baby is preterm, the more the sequelae will be more serious. If the baby is more mature, the sequelae will be less. So what are the neonatal outcomes? As again, neonatal death, severe brain injury, if there is meningitis, severe BPD, or preterm labor. Okay, especially and BPD, especially in preterm labor. And we said ceftriaxone does not have any role. And this is to sum up, and I'm going to send you all these pieces of information. And this is like a summary of all what we said. Epidemiology, you cannot tell exactly because many of the mom are missed. You don't diagnose them. And we said why. There is something important. Usually, this listeria is the body can fight listeria through cellular immune function, and because the T cell function is diminished in pregnancy, especially in late pregnancy, so that's why listeria can affect pregnant mothers more than other persons. And of course, the newborn babies have some immune issues, and we are going to discuss this more in the next question. Okay, and this is an example of how bad is this problem. So listeria is estimated to be responsible for 2 to 3 outbreaks. This is in the States, and there were 1,600 illnesses, 1,500 hospitalization, and 260 deaths. So it is not a benign disease. It's something that need be carefully treated. Okay. What are the sources of food? Usually it comes through ingestion of contaminated food. And the commonest is the dairy products. Then comes the meat, but other food can transfer, like can be contaminated and give infection to whoever will ingest them, like ice cream, boiled eggs, mushrooms, cantaloupe, whatever. But the daily products are the most famous, and then comes especially the unpasteurized dairy products and the daily meats that you buy from the daily store. Pathogenesis, I will just comment on the, okay. So the fetus may be exposed to Listeria monocytogenes via, as we said, transplacental, or during passage in the birth canal, the baby might ingest the amniotic fluid, which is contaminated, or because of ascending infection from the vagina, because of vaginal contamination. And the listeria causes illness by invading host cells, such as the enterocytes, fibroblasts, hepatocytes, every cell, and breaking free from host. She can run away or defend her or herself against phagocytosis. Okay, and they are intracellular bacteria. They can multiply within the host cell. Okay, and they use some other mechanisms, and this is how they present. We talked about the mother and how they present in the fetus, and it can cause up to 40% of stillbirth of the affected fetuses. And then the baby can be affected, and this affection can be very severe, can cause disseminated miliary disease called granulomatosis infantiseptica. Okay, it's the severest form, and it can present with a skin rash, and it can present with pathological findings on the placenta. That's why every and each time I stress on, please look at the placenta of every and each baby, especially if you have high risk, especially if the mom is suspected to have chorioamnionitis or have infection like listeriosis, because you can, by the naked eye, microscopic examination, pathological and microbiology examination of the placenta, you can reach a diagnosis which can help you manage your baby. This is extremely important. I stress on that, examination of the placenta. And it's a good article to present by one of our dear residents, is to talk to us about the placenta and the umbilical cord. And you go from, starts from scratch, from embryology to functions, to pathology, to whatever. And you will find a lot of issues that you can discuss. And I can help you, giving you what you need of references. It's a very good topic, the placenta and the umbilical cord, term, preterm, normal, healthy baby, and in pathological conditions. Early onset sepsis, late onset sepsis, respiratory distress and fever, these are all different presentations. Or it can start with non-specific findings, just poor feeding and non-specific signs of sepsis, like many other infections. And also, one of the issues when we attend the delivery, look at the fluids, the maternal fluids. Are they meconium stained? And in case of listeria, amniotic fluid may appear greenish brown. Greenish brown. You will not find greenish brown amniotic fluid except in listeria. Okay? Or can present as late onset, and it could be very invasive, as we said, even up to meningitis. Okay? And this is, oh yeah, you can also diagnose listeria by PCR, but you should do culture. Why? Because you have to do sensitivity to antibiotics. So even if you do PCR and you are sure this is a case of listeria, you should also do cultures, blood culture, urine culture, CSF culture, skin rash culture, whatever culture, and decide antibiotic sensitivity and susceptibility of the strain you are having. And we talked about 14 days treatment, or if there is meningitis, up to 3 weeks. And we talked that you have to add aminoglycoside like gentamicin, because they have synergistic action and it helps enhancing intracellular killing, because it's an intracellular parasite. Prognosis, as we said, fetal death up to 20%, premature delivery up to 50 to 60% of cases. But however, more than 50% will be symptomatic with either bacteremia, pneumonia, meningitis, early onset sepsis, late onset sepsis. Okay? And the mortality can be up to 30%, 20 to 30%. Early onset sepsis is up to 56%. Late onset is up to 25%. Questions, comments? So any patient baby born to mom with rash, fever, chorioamnionitis, we should ask blood culture with insist on listeria. Yes, the answer is yes. But my point was not that. My point was, I was commenting on Dr. Marwa comment when she said, we suspect, but we don't diagnose it frequently. And I told her, because you could be missing cases, because most of the time the lab, the microbiology guys will say, oh no, this is just diphtheroids. It's a contaminant. Unless you stress to tell them, oh, hi guys, please, I'm suspecting listeria. Please, can you check for listeria? And then they will look seriously for listeria. And if it is there, they will diagnose it. This was my point. Any question? Any question? Any comment? Before we move to the next question, which is extremely important. The next question is extremely important. Is it poor prognosis than GBS? This is a difficult question. I don't know. I didn't read about comparing severity of GBS. Maybe this is a good study. If you are interested, you can make a research and compare babies positive for GBS with those positive for listeria. But you will need a lot of babies, which I doubt you will be having. You will be able to fulfill the sample size. And another issue, every one of you insists that you don't see GBS in Alexandria, something which I cannot believe. I cannot, I don't know, but GBS is something that it's not only in USA, it's international. However, you don't find it. Okay. Can answer my question, doctor, in Q&A, please. Q&A. Q&A. Okay, Q&A. Q&A. Okay. Q&A. Why pregnancy suppressed T cell? I don't know. This is outside my my area of expertise. I don't know. I don't know the mechanism. I'm sorry. You can ask a labor and delivery doctor. Can baby catch listeria via breast milk? It's a very, very good question. And I believe if mom is having bacteremia, I believe yes, because the baby can get it post, not only antenatal or perinatal, but postnatal. I believe, I didn't read it, but I think it's a possible, but I will look for that. It's a very, very good question. What route of transmission of listeria as cause of late onset sepsis? It is the same as every late onset sepsis. I don't know what do you mean by that. It could be transplacental, it could be ingestion of the infected amniotic fluid, it could be ascending infection during delivery, it could be the ingestion of infected secretions or whatever, even after delivery. And it can present either early or late, like any other infection. This is not something specific for listeria. I believe this is the answer for your question. Okay. Comments. Chat again. Thank you. Okay. We need to hurry up because I have 3 MCQs and 3 cases. And they are very important. Now, we have a newborn at 32 weeks who develops tachypnea, tachycardia, grunting respiration, hypothermia, 12 hours. This is a very sick baby, most probably have sepsis. Blood and CSF, so she has also not only bacteremia and septicemia, but also meningitis. Reveal E. coli. Oh, E. coli. It's a very bad gram-negative enemy that can affect babies, especially the preterm ones, 32 weeks. But this is not the question. Medical students are allowed and should round with the residents, fellows, and the staff, the academic staff, like the professors or whatever. And this is part of their curriculum. And usually they ask, which is a good sign. You don't learn if you don't ask. So this medical student has a comment. How fast neonates develop an overwhelming bacteria or viral infection when compared with healthy adults? And then they started the discussion, and among the discussions raised some points. One of them is the advantages and limitations of these neonates' innate immunity response to bacterial or viral pathogens when compared with adults. This is a complex question, but it is extremely important. I will simplify it. If you compare the immune system of the newborn baby, term and preterm, anytime you mention newborn baby, you should talk about term and preterm. Immune system of the newborn baby, term and preterm, compared to the immune system of adults. What is good and what is inadequate or immature or not enough? By the way, this is extremely important point because there was many theories in this field. Some people think that the immune system of the newborn baby, especially the preterm one, is a naive immune system, meaning cannot discriminate between self and non-self. And if you give any bacteria or viruses or foreign body, he will say, hey, hello, this is my friend, you are not an enemy, you are self. This is on the extreme. On the other extreme, some people think, and all this based on studies, old and recent, some people think, no, the immune system of the newborn baby, especially the term one, is very competent, it's very mature, and it's comparable to adult. Now, what is the truth? The truth is we are in the middle between those extremes. The immune system of the newborn baby has some limitations, but it is functioning. And what is the proof for that? We have very simple proof for that, which is we immunize, we give vaccination to newborn babies, correct? And they have very good immune response. And these vaccinations give them protection against disease. So they have a functioning immune system. But how functioning, how mature, what are the disadvantages? This is a big story. And before we go to the question, I will give you a very simplified presentation of the immune system, which makes your life easy. Because immunology is not an easy topic or subspecialties. And we should have pediatric immunology and pediatric immunologist, allergist and immunologist as a subspecialty. It's extremely important. So we are going to start from scratch in a very simplified way. What are the components of the immune system, adult and newborn? Number one, we have some physical and chemical barriers. And what is the value of the immune system? It is to protect your body against any invasive, bad, foreign material like bacteria, viruses, protozoa, amoeba, whatever. So it is your defense, it is your army. It is the army that protects the body against infection or foreign bodies in a very simple way. If you go into details, you will find a lot of issues under that. So number one is physical and chemical barriers. Like what? Like the skin, which is a very good proof, waterproof shield. That's why if you have skin disease like ichthyosis or severe problems with the development of the skin, the baby is very liable to get severe infection. And then comes mucous membranes, and this is in the upper and lower respiratory, in the GI, in the eye, in the nose, in the whatever. It has protective mechanisms. And then comes some specific issues like the acid of the stone, which can kill microorganisms. Then what are the organs involved in the immune system, which we call the lymphoid system? Lymphoid, not lymphatic, the lymphoid, okay? We can have all these organs, and each one of them has a great function. The bone marrow, the thymus, the spleen, the lymph nodes, the tonsils, and adenoids. And many of those start working in utero when the baby, for the fetus. They work for the fetus in utero. The bone marrow, it's the factory. It can make all the blood cells and all the blood cells that deal with the phagocytosis and other functions, like the T cells and B cells and whatever. And then to become a T cell, in utero, the cell should go to visit the thymus, and then there will be stamped T cells, and they have different functions. And then the spleen, which is part of the immune and lymphoid system, because it acts like a filter. It acts like a filter, and there is some opsonization method, and there is some underlying mechanisms. And comes the lymph nodes, which is the same. If the spleen is the filter, the lymph node is the trap. So when you have an enemy, you have to surround that enemy with cells, with chemicals, with proteins, specific cells, T cells, and B cells, like the Bursa equivalent, which is not mentioned here, but it is in utero. It will make the cells signed, stamped as B cells. So you have T cells, B cells. Spleen is the filter, lymph nodes that trap, and tonsils and adenoids, and more or less they are like the lymph nodes guarding the upper airways and upper GI. Then comes the cells. The cells, the soldiers, these are your soldiers of your army. And you divide them into either innate, which is the fast responders, meaning you have two types of soldiers that are ready to attack any enemy, but irrespective of its nature. They don't need any preparation. They are ready day and night, having their weapons ready. These are called the innate squad. And this is either phagocytes or natural killer cells. The phagocytes, either neutrophils, mononuclear neutrophils, macrophages in the tissues, okay? The natural killer cells, we have different types and stages, but they are ready. They don't need any previous preparation. And comes the adaptive squad, which is the specialized forces or armies or soldiers. الصاعقة, المظلات, قوات الطيران, قوات البحرية, okay? So these cells take some time to get prepared, because if you have an enemy attacking you with aeroplanes, you have to prepare some type of defense. If attacking you with rockets and missiles, you have to have another, and so forth. So they need some preparation. They are not, in real life, they are ready, but they are dormant, and you have to call them and make them ready to fight specific problems. And example is the B cells and the T cells. And there is under subtypes of each one of them. But to make your life easy, B cells, humoral immunity, antibodies, T cells, T cell is cellular immunity, and mostly either T helper or T killer, and there is subtypes. If you need to go into details, if you are very interested, you can go more in depth. What is the lymphatic system? It is the highway for the immune system, meaning it is when you need to go from one place to another, you have to take the highway. So it's a network of thin tubes and branches that present all over the body, throughout the whole body. And it has lymph, which is a clear containing white blood, clear fluid containing white blood cells, and they drain waste products from tissues. They move cells from one place to the other, and they get rid of the waste products of the battle between your immune system and the body. And then comes chemicals and proteins. And proteins, antibodies. You have IgG, IgM, IgA, and subclasses of each one of them. You have cytokines, which are chemicals. It is a chemical sent from one cell to the other to signal the attack. خد بالك في فرقة جاية من الناحية الشمال مظلات، يبقى السيتوكاين بتاع المظلات يروح يقول للسيل دي كلمي السيل دي. And then the complement system, which is a group of proteins. It's a cascade. You know the cascade of blood coagulation? It is a cascade like blood clotting proteins, and it has two pathways, the classical and the alternate pathway, okay? And then comes another terminology that you are going to meet in your readings, which is activated immune system. There is nothing called, or in real life, is activated immune system, because every and each part of the immune system could be activated. The classification is either innate or adaptive. Innate or adaptive. This is the main classification. But if one of them is activated, it will be activated immune system. I think this is a very simple way to understand immune system. And under each one of those slides, there is tons of information, tons of books, but you don't need to know that in details because you are not an immunologist. Okay? And this is a comparison between the innate and the adaptive, the rapid squad and the slowly acting squad. Or the innate system is the first responders, and the adaptive system is the special forces. And activity system, we talked about that. And there is a good relationship. There is a relationship between every and each component. None of these components is working on its own. Meaning the B cells don't work without requiring T cells or the other way around. They help each other. They interact with each other. They support each other, like any very, very advanced army in the real life. Okay. Now we come back to the question. Okay. Of the following, the innate immune factor and the neonate most similar to that of an adult is the alternate pathway of the complement concentrations, the monocyte killing of bacteria, the natural killer cell cytotoxicity, or the neutrophil respiratory burst. What is the neutrophil respiratory burst? When a neutrophil ingests a microorganism, there is a chain of chemical reactions that lead to the production of oxygen radicals that kill the invading organism. This is called the neutrophil respiratory burst. And natural killer cell cytotoxicity. This is, as we mentioned, some type of cells that are ready to kill the bacteria or virus or whatever. And then monocyte, the monocyte is part of the phagocytic system. It's part of the innate, should be ready to attack the microorganisms, and the alternate pathway of the complement. What do you think? C, 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 C. Okay, all of you say C. Okay, let us go a little bit in depth. So, activated monocytes have phagocytic and microbial activity. They secrete pro-inflammatory cytokines, and they have the ability to present processed foreign antigen to T cells. So if they find an invader, a bacteria or virus or any foreign body, they attack, and they have microbicidal activity. They start killing these invaders, and also they secrete inflammatory cytokines. And once they digest and kill and digest and process the invader, they present it to the T cells. Okay, this is very simple. So this is the only function in the immune system of the newborn baby that is more or less similar to that of adults. Other components are not, are more or less immature or not that mature as in the adult. This is to make a long story short. And definitely in the newborn babies, the preterm ones, also they are more crippled. They are more crippled. I will not go into the minute details because it will take us hours, but I am going to send all these pieces of information to you. And but this table, this table is talking only about the innate immune system in the preterm compared to adults, and talking about cellular components, neutrophils, monocytes, natural killer. All the functions are less, and the cytokines less. Interleukins, less. The same, tumor, chemotype, or less. Okay, so the only one that is more or less comparable to adults, especially in the term, is the monocyte killing activity. And the preterm is more compromised. Okay. I don't know why it's okay. Yeah, and then comes the other chemicals, and then comes the complement. These are minute details for anyone interested. Any question, any comment? I tried to simplify this question as much as I could, but definitely I didn't go into any details because I'm not an immunologist, by the way. And if you need something, you should consult your pediatric immunologist, or you can go and read online or books. Comment, question before we go to the third one. You see how much information I gather and collect, but it's hard to present all. We need a lot of time. And this is like a summary of what happens, very, very simplified form. And this is the enemy, the bacteria. And this is the pathway for forming antibodies. And this is the pathway for going into cell-mediated immunity. Tons of details. Then come to question number 3. A neonate is born at 24-weeker. Oh yes, this is a very practical question. Undergoes placement of a PICC line. A PICC line. It at the left basilic vein at the age of 10 days for TPN and maybe antibiotics if he needs and other medications. The central catheter tip position is verified on anteroposterior chest radiograph after placement, and the catheter is secured in place. So they did insert a PICC line in the left basilic vein, and then they verified the position of the tip, and then they secured the PICC line. Before we go to question, my question to you, Dr. Amaro, how much you do PICC lines in the NICU?
كتير يا دكتور، احنا تقريبا ده
You do it.
لاين بعد في
Great. So this question is extremely important. Another question for you. And is it guided by ultrasound, or you do because sometimes when we have difficulty placing a PICC line, we send them to the conventional radiology department, and they insert the PICC line under ultrasonographic visualization. And do you do that? Do you get
لا
help?
للأسف هو
We confirm placement or tip of the PICC line by ultrasound and use ultrasound to detect complications, but we didn't use the ultrasound guided PICC line. We use ultrasound.
Why not?
Guided.
As long as you use it to detect position. And so if it is difficult to insert, why not you use the ultrasound, and it will help you a lot to insert? Why not?
I think our ultrasound frequency is not appropriate for the very, very superficial veins of the skin. It
So
needs
some technical problems, which I don't know, but can the radiologist help, or they don't care about that? Never mind, but this is what happens here. So another question, where you insert your PICC lines?
upper limb, basilar, cephalic, and also long saphenous, peroneal, external jugular.
So it's either upper limb or lower limb. In the upper limb, what veins you are using?
Cephalic and basilic.
Do you use the basilic? Do you use the anticube? Do you use the cephalic? Or you go high and go to the subclavian immediately?
No, we insert to the basilic and cephalic. Sometimes hand veins, although it's difficult. Some babies we do PICC line in hand veins.
Veins of the hands. You start that distal.
Yes.
Yeah, it's either the most common is in the upper limb. Usually we don't need, sometimes we need to go to the neck and head, of course. If you don't have any peripheral veins, you have to go to the main veins, central veins. It's okay, but you have to start with the upper limb or the lower limb. Start with the basilic or cephalic. You start with the saphenous or popliteal, or if you don't have any choice, you go femoral. Correct? Yes or no?
Doctor, no, we usually for femoral vein and subclavian we use CVB, but long lines with 3 French, 4 French.
So it's not a big.
But for big lines we use peripheral veins
Okay,
only.
great. So you use cephalic, basilic, or antiq, or popliteal, or saphenous. Correct? Here comes the third question. Okay, what is the normal? I don't mean normal. What is the appropriate place or site for the tip of the PICC line if it is inserted through an upper limb and if it is inserted through the lower limb? Dr. Marwa, don't answer, please. Let the guys answer because they are the ones who do PICC lines. They told me do hundreds of PICC lines every day. Okay, SVC and IVC. This is incomplete answer. SVC in third, ICS in third, just before the right atrium. Give me landmarks. And you have to use fixed stable landmarks. And what are the fixed stable landmarks? They are the vertebrae. The vertebrae. Okay? So, if you insert an upper PICC line, where should the tip of the PICC line be in relation to the vertebrae? Lower T, T8, 9. I need the guys who do it by their own hands to answer this question. If it's an upper PICC line, which vertebrae? If using a lower limb PICC line, which vertebrae? Because this is everyday practice and you should know exactly you are doing the correct procedure. I see T8, T9, lower T10, lower T10. Is there upper T10? What does this mean? You mean the lower, yeah, okay, the lower rim or whatever. Okay, T6, T9, T4. So there is no agreement. And also another question, because the PICC lines can migrate, and they are not very simple procedure. It is very hard to place, very hard to keep in place for some time because they can migrate. In order to know where they could migrate, you should know the anatomy of the veins of the upper limb and of the lower limb. So my question is, if you insert a PICC line in the upper limb in the basilic vein, what will be the course? And where should be the tip in relation to the vessels and in relation to vertebrae? We talked about vertebrae. In relation to vessels, what is your aim? You go through the basilic and then what? Where does the basilic nerve drain?
It's continuation of axillary vein. It continue as axillary vein.
And then, okay, so you say axillary vein. What's next?
Subclavian.
What's next?
Right or left?
This is extremely important, my dear friends, because if you have this in the back of your mind, you can imagine how and where the tip can migrate. Sometimes I saw PICC lines that migrate from the upper limb up to the neck veins. Sometimes they migrate to the opposite side, from the right to the left, and go into the veins of the left side. That's why it's extremely important to do your measurements, extremely important to check your point, the tip, where is the tip, and you have to secure it very, very well so it doesn't move. And also, whatever you do, sometimes they migrate because the baby keeps moving his body, his hands, his lower limbs. And if you are doing a lower limb PICC line, say through the saphenous vein, what is the journey of the PICC line up to the IVC? Okay, I will try to help you, and I hope this is going to stick to your memory. Okay, now we have the anatomy. Of course, we didn't see this since anatomy lessons in the first year in the faculty. Okay, we have, of course, we have the peripheral veins, the radial and ulnar, and then comes the cephalic vein and cubital vein, and then the basilic and the cephalic, and then it will end up, as Dr. Omar said, as a axillary vein. Axillary vein will end up in the subclavian, and there is, here we have the internal jugular, we have the brachiocephalic vein, and then you have to go this way. It's a very difficult journey. How can you be sure that that line will go this way? Even when you insert it, if it is too far, it could go this way up, could go the other way around. And sometimes when it migrates even to the pericardium or to the pleura and can cause pericardial effusion. And you have a baby preterm on TPN, and all of a sudden you find that your baby is crashing on you, baby is collapsing, is shocked, and you don't know why. Everything was going very well. The baby was on minimal oxygen. And then if you keep digging, you will find that this baby is having pericardial effusion caused by TPN, which is very irritant. So you have to have this picture in the back of your mind. Then these are the veins of the lower limb. Of course, you go from the dorsal veins, anterior and posterior tibial veins, popliteal, which is a very good site for insertion of the PICC line. And then we drain into the femoral, external iliac, and then external iliac and internal iliac will form the common iliac, and we'll go to IVC. It should, the target should be the upper third of the I don't know if it's upper or lower. I will check it for you now. One of the thirds of the SVC, because the wall is thick, and the same for the IVC. And note that the anatomy on the right side is different from the anatomy on the left side, especially for the arterial supply. The anatomy of the circulation is a little bit different on the left side from the right side. So let us go back. Oh, yes. And these your bony landmarks. And you have to mark the thoracic vertebrae and the lumbar vertebrae, and then we'll decide if the tip of your PICC line is in a good position or not. Back to the question. Of the following, the best time to obtain a follow-up radiograph to evaluate this infant's catheter tip placement is 24 to 72 hours, 1 week, 2 weeks, only when clinical concern arise. And when you answer, you should tell me yes. You should tell me why. 24 hours, but the option is 24 to 74 hours. So you are going with option A. Okay. Let us see what is the correct answer. Peripherally inserted lines, the big lines, provide extended intravenous access in neonates and administer TPN. However, they can be associated with threatening complications. Number one is malpositioning, which is during insertion. It significantly increases the risk of the development of catheter-related complications. Of course, sepsis and infection is the most common. And serial radiographic monitoring to ensure appropriate tip position is warranted. You have to follow your PICC line. And the answer is based on statistics. It's based on statistics. Up to 50% of cases of PICC line migrate during the first 24 to 72 hours. They did their statistics, they did a study. And also if you need a very easy topic for master thesis, you can do this. It will take you a few months. You will do just X-ray and follow up of your PICC lines, and you will have a result which may or may not go with this study, which is 24 to 72 hours. Okay? With migration in most cases inward. So they migrate inward, usually towards the right atrium. And if they hit the right atrium and they go inside there is a very important structure in the right atrium, which if they hit it, they can cause arrhythmia, which is the SA node, correct? One of the complications. The critique, okay, so it's either upper limb going to the superior vena cava or lower limb going to inferior vena cava. Complications include pericardial, pleural, and peritoneal, even peritoneal effusion, pericardial tamponade, occlusion, a breakage, or if it breaks, you have to go to vascular surgery to take it out. Leakage, which is something serious. Infection, arrhythmias or dysrhythmias. All these are possible. So you have to be very vigilant, and you have to watch your PICC lines and serially follow it up with X-ray, especially in the first 1 to 3 days. So what is the optimal position? Okay. In the vena cava, the tip should be in the vena cava, close to the atrial caval junction. So it should be close to the junction between the superior vena cava or inferior vena cava and the atrium. Why? Because this wall is thick. This wall is thicker and less prone to perforation, which is a complication. So the position also provides increased blood volume and turbulence, which allow dilution of hyperesmolar influence. It can interfere with the osmolality of your fluids and can cause endothelial chemical irritation or injury to the vessel. And this can start the process of perforation or infection. Okay. The placement of the catheter tip distal to the vena cava subjects the PICC line to smaller diameter vessels, curvature of the vein and venous valves, each of which increase the risk of causing mechanical or chemical irritation. So if you go more, you bypass the vena cavas and go to continue the peripheral veins, they have a smaller diameter, curvature, valves, which increase the possibility of irritation, of complication. Irritation can lead to various complications and thrombosis, thrombophlebitis, infection, fluid infiltration in non-elective peak removal. You have to remove it. So now we come to positions. Okay. The distal position of the peak line in the lower third of the SVC for upper limb. So you are aiming at the lower third of the SVC in the upper limb peak line. And if you do scalp or neck, and if you do lower limb, you use the upper third. Yeah, so you are trying to be close to the atrium, either the lower third of SVC or upper third of IVC. So this corresponds to what? What is the landmark? This corresponds to T3 to T5. I don't think I saw this among your answers. T3 and T5 for upper limb decline. T9 and L1 is for the lower limb, which is just below the atrium and above the diaphragm. So these are the landmarks. T3 to T5, upper limb. T9 to L1, lower limb. Okay, I will not go into more details, but yeah, and this is, we talked about that, 24 to 72 hours. We talked about complications. We talked about the anatomy and when you should repeat an X-ray. And then comes, we are done with the MCQs. If you give me like 4 or 5 minutes break, I will be back again with the cases, okay? Just you break. I'm back again. Sorry for interruption. Do you hear me?
Yes.
Yes.
So, okay, I will open the cases. Cases. Then slideshow from the beginning. And do you see it? Hello? No, you don't see it.
Yes, we see you, Doctor.
You see January, February, March, and April 2026 newborn cases?
تمام مظبوط.
Great. Okay, we'll start. But before we start, just FYI for your information, presenting rare cases doesn't mean that we are giving you something that is not important. But the beauty of these cases is in the differential diagnosis and in the smart clinical approach. And although common things are common, and you see, you used to deal with many common cases, but sometimes this will make us behave like a robot and don't think of rare issues which can happen. Although they are not common, but we don't need to miss them. And at least think broadly. And if everything fits for the common, well and good. If you are dealing with something rare, don't miss it. Okay. Case number 1. This is an infant readmitted after going home, readmitted for severe acute respiratory failure. So the differential diagnosis will be a baby who went home and at some point developed severe acute respiratory failure, something very serious. So we have a 60-day-old formal 34-weeker and 5 days came to the pediatrician office for new onset fasciitis. Fasciitis is increased irritability. His birth history was notable for an 8-day neonatal intensive care unit, stayed in the NICU for 8 days, received some CPAP after delivery, and then weaned off quickly. Initial chest regraph was negative during initial hospitalization. There was no abnormalities as shown in this babygram. This is a babygram, and the baby has a UVC, and this is the cardiothymic shadow, and this is the chest. We don't see any evidence of like collapse or infiltrates or pneumothorax or something weird cyst, or it looks very, very normal. However, after 8 days, he was discharged home and on room air, full feeds. And initial X-ray was reported normal. On day of life 60, he was brought to the pediatrician because of fasciitis, and this was like 2 hours ago. So it was something acute, very acute. The mother or the parents took the baby to the pediatrician for 2 hours history of fasciitis at the age of 60 days. So, and this happened immediately after feeding. Immediately after feeding. You have to be wise enough to select the keywords. I will not refer to the keywords. Acute onset, fasciitis, 60 days old, previously healthy, late preterm baby, immediately after feeding became inconsolable, does not stop crying, rapid onset laboring breathing, respiratory distress. There was some sick contact with a sick sibling, and she denied trauma, because when you have some weird history, you have to rule out child abuse or trauma, accidental or non-accidental. Okay, the baby was grunting with severe retraction. Oh, there's something serious going on. He was tachycardic also, heart rate 200, tachypneic, oxygen saturation in the 90s in room air. So he didn't drop his or her sats yet. It is he or she, I don't remember. They didn't mention. His or him, okay. So his heart rate 200, tachypneic, oxygen saturation 90%. Based on the vital, immediately taken to the ER emergency room. And this idea just came to my mind now. Do we have an emergency room in Shabbi, Tora Marwa? Emergency department?
For neonates ولا for all babies? We of
Any
course
baby.
have
Or any baby from birth to the age of 21 years. Do we have emergency department?
Yes.
Okay, good.
Yes, of course.
So if this was in Shabbi, this baby should go to the ER first, and then they will do the stabilization and send the baby to like the pediatric ward or to the NICU or the PQ, whatever. Baby also was hypothermic. Baby was shocking, was shocked, and demonstrated increased working breathing, severe respiratory distress, also tachycardia. And baby was immediately intubated, and they considered him, although his oxygen saturation was 90% in room air, but he was in impending heart failure, respiratory failure. So they didn't wait for the saturation to drop to 40s or 50s. They did immediate intubation. Okay, if you are the doctor, the physician who received this former newborn baby that is now 60 days old, but the story might be related to the newborn history. What is your differential? This is the major part of this case. What is your differential? A former late preterm, 35 and 4 weeks and days, 4 days, acute, severe respiratory failure, and maybe some other issues because of the tachycardia also. So tracheostomy, and it was, yes, it started immediately after feeding. So, yeah. So you mentioned tracheoesophageal fistula. It's a good possibility, H type. Cardiac arrhythmia, we don't know about that, but it could present similar to this presentation. Aspiration, yes. Choking. SVTs. SVTs with heart rate of 200, it is borderline, but it is not enough to diagnose SVT. It should be more than that. After feeding as a aspiration. Sepsis, yeah, we know that the sepsis is common in every and each presentation. GERD, I don't know. Can GERD present with severe acute respiratory failure or bronchiolitis? Bronchiolitis it's viral infection. There should be other symptoms. There should be nasal congestion, some rise of temperature, some cough, sneezing for some time, and then the baby will start slowly going into respiratory distress, maybe in few hours, but this baby succumbed in 2 hours. Bronchiolitis, I don't think it's a good choice. RSV infection, it could be also, but it will take some time, but both are in your differential. Adenoviral infection, it's viral infection. What else? Again, GERD, maybe DO. What is DO? Shocked. What is DO? Vascular ring. And why it presented that acute? Why the vascular ring presented that acute? Surgical. What is surgical? What do you mean by surgical? And what do you mean by GERD, maybe DO? I'm sorry, I don't get it. Shocked, vascular ring, surgical, foreign body. Yes, foreign body. It could be obstruction, or it's an upper airway obstruction. Pulmonary hemorrhage, just out of the blue. I don't know. Everybody's insisting on the gastroesophageal reflux disease. Pneumonia, ARDS, ischemia of LCAPA, anterior left coronary artery, PA ischemia. You mean left coronary artery syndrome with ischemia and myocardial infarction and severe heart failure. I don't know, is this baby in heart failure or respiratory failure or both? Congenital diaphragmatic hernia, Manal, Manal, Dr. Manal, why you think of congenital diaphragmatic hernia? Dr. Manal, congenital diaphragmatic hernia, why? Okay. You miss very, very important diagnosis, which can act like a time bomb and even cannot present in initial X-rays. Like CPAM. CPAM is an important differential diagnosis because it could present anytime when the cysts rupture or get enlarged or rupture and cause pneumothorax. Yes, you didn't mention CPAM. All other problem will take some time. The congenital heart presenting with heart failure in this age, there will be some like prodromal issues, feeding intolerance, some tachycardia, the baby is fussy, does not sleep for a few days, and the same for vascular ring. Vascular ring will have also feeding issues, respiratory issues, upper airway and GI obstruction. Post-viral congestion, heart failure. Post-viral. Yeah, but this baby did not have any viral post to be followed by heart failure. This baby had history of 2 hours immediately after feeding. Dr. Manal, so you meant by congenital heart disease? I thought you meant congenital diaphragmatic hernia. I was very happy with you, but you changed your mind. Okay, so it could be something acute, or it could be something congenital that was missed or not presenting, and then acutely presented. This could be the possibilities. Acute, you mentioned choking, aspiration, tracheoesophageal fistula, some upper airway obstruction, if there is like a mass and there is hemorrhage in the mass, all these are possibilities. Or congenital issues that were not detected or not presenting and then acutely presented. This case is very rare, presentation is very unusual, but it is good for differential diagnosis and for smart clinical approach. And when you see the result, the diagnosis you will become astonished. So this is their differential. The differential diagnosis of an infant with no known congenital abnormalities so far. They assume that there is no congenital abnormality so far, who presents with severe respiratory failure and inconsolability requiring intubation is broad. The most common suspect of cause of is infection, also pneumonia, also viral infection, also RSV, والحاجات دي. I don't think it comes on top of the list, including viral infections. Okay, you mentioned all that. Bacterial pulmonary infection, pneumonia, you said that. Bloodstream sepsis, you mentioned sepsis, meningitis. Delayed, this is another option, another possibility. Delayed presentation of congenital pathologies is a consideration, including cardiac disease, you mentioned that. But I cannot swallow that cardiac disease will succumb. At the age of 60 days, you know what, if this happens at the age of 5 days, week, when the ductus closes, yes, I can take that. Yes, the congenital heart disease that is ductal dependent. Once the duct closes, the baby will succumb and be in shock, maybe. Okay, but at the age of 60 days, I don't think there is a ductus at this age that will close and will make the baby succumb. However, he included this in his differential. Congenital diaphragmatic hernia, congenital lung malformation. You didn't mention congenital lung malformation at all, like CPAM. And you didn't mention congenital diaphragmatic hernia. Maybe Ala just mentioned it now. Some person is saying PPHN. What I don't, this is a very remote possibility. This is a very remote diagnosis, my dear friend. No way for PPHN. Please go and review your PPHN course and lessons. Okay. Additional etiologies, rare, like inborn errors of metabolism that can cause acidosis. Airway obstruction, yes, you mentioned that. So airway obstruction, congenital pathologies that was not diagnosed initially, mainly congenital diaphragmatic hernia and not CPAM or congenital lung malformation, and infection, including sepsis. Common causes of, then he tried to broaden. Actually, he should have mentioned this before talking about respiratory failure. He should mention these common causes of inconsolability. At this age, yes. If you have, this is another differential diagnosis which was ruled out because the presentation changed dramatically. But if you have a baby who is only inconsolable at the age of 60 days, what is your differential? And this is very common. You will see this a lot. Abdominal pathologies like intussusception, constipation, non-accidental trauma, meaning child abuse, or hair tourniquet. Do you know what is the hair tourniquet syndrome or sign? This is extremely important. And if you can miss a lot of such cases. What is the hair tourniquet syndrome? Before you go to the AI, what do you know about the hair tourniquet? Okay. This is very common because many of the ladies, of the women, pregnant women, and when they give birth to babies, and they take care of the baby, newborn babies. There is a lot of them who lose some hair. The hair will fall, okay? Sometimes the hair will fall in the diaper, and the baby is moving around back and forth. He's moving, and this hair will go around the penis, will encircle the penis and will cause ischemia. So if you have a fussy baby and you are doing full examination and you don't examine the penis, you will lose this diagnosis, you will miss it. And the treatment is very simple. You just take this hair out, okay? X-ray was normal as I remember, yes, as we all of us remember. So why don't see the diaphragmatic hernia? You are going to see it now, my friend. Okay. You are going to see it now. Okay. This is a very difficult case, and it is not easy because initially the diaphragmatic hernia, for some reason, it was moving up and down, up and down. So at this moment, it was down and it was not symptomatic. Maybe the hole was still tiny, or maybe the baby was, I don't know. I don't have explanation, and the guys here don't have explanation, but this is what they found. So what they found is they did a repeat radiograph, which showed ossification of the left chest, which is in figure 2. And they did echocardiogram that presented normal cardiac function. The heart was normal, so we ruled out a cardiac problem, but there is a chest problem. This is the X-ray. And I need one of you to comment on this X-ray. I need one of you to read it. Okay, MA, you are the one who was asking for the X-ray. Please read this X-ray for us. Either you can talk or write, it's up to you. What is wrong with this X-ray? There is opacification of the whole left hemithorax, and this is the left lung, very tiny, compressed. And if you look carefully, what is this? What is this? What is this gas pattern? Does it remind you of something, this gas pattern? It looks like bowel loops. Correct, it's bowel loops. Okay? So this was intestine full of food and milk and stuff. That's why it looks like that, opaque, opacified. And now it's huge enough to compress the lung and cause severe acute respiratory distress and respiratory failure. And when they looked carefully, they found those bowel loops. And then they did CT, whole body, and then chest. And this, you see, found many lobes of gut, opacification. And you don't see even the left lung. And then when they did they did contrast enhanced CT. This is, you can see, this is what's left of the lung, and this is all gut. It's all bowel loops. Okay? So this case was very tricky, and this baby went to surgery, and we're not going to discuss congenital diaphragmatic hernia or talk about that. And I know it's rare, it's a very weird presentation, but the differential diagnosis is important. You have to think smartly, and common things are common, and then go to the less common, and then go to the rare, and don't miss the rare conditions. Lesson: congenital diaphragmatic hernia should remain on the differential for post-birth respiratory failure, even not non-prenatally with normal post-birth imaging. This is the homegoing lesson. Just keep it in the back of your mind. Questions or comments? Case 2. Another very rare, but it's very important because it opens the discussion of acute abdomen in the newborn baby. Acute abdomen or acute surgical abdomen in a newborn baby. This is a male boy, 25, 160 grams, 28 weeks, C-section, had some fetal distress. Mom is 21-year-old, C4 para 3, G4 para 3. Okay, the baby was AGA, no obstetric complications, and had some mild respiratory distress. And this also, they ruled out early onset sepsis, and it was treated, baby stabilized, went to room air at the age of 5 days. And the baby was fed, given enteral feeds, express breast milk through an OG tube on day 3, and then they kept up escalating the feeds. However, on day 7, signs of feeding intolerance. Baby started to show some weird, non-specific manifestations, and then abdominal distension and passage of bloody stools. If you see this baby at this point, 7-day-old with minimal issues in the first early neonatal life, mild respiratory distress, ruled out sepsis, started gavage feeding, and then all PO feeds, was doing well. And at the age of 7 days, feeding intolerance, and then abdominal distension, and then passage of bloody stools. What is your differential? Because you could see this. And be careful, because at this point, the baby was not sick or very sick, just feeding intolerance, some abdominal distension, which may or may not happen to any newborn baby, and passage of bloody stools. Neck volvulus, intussusception, Samba, CMPA. I don't know what the CMPA means. SMAPA. Yeah, this could be necrotizing enterocolitis. The problem with neck in the term and near-term babies is that it's not classic. It's not the classical way we see in the preterm babies, because neck is a disease of the preterm babies. So it could be very fulminant, it could be very acute, very severe, and it could come just out of the blue, but more common in babies with history of HIE, of hypoxia. This baby didn't have that initial severe respiratory issues, just mild respiratory problem, CPAP, went to room air. So it didn't have HIE or severe anoxia or hypoxia, and is not a preterm baby. However, you should rule out neck. And then you say spontaneous intestinal perforation. Okay. Hala, can you explain more in how and when spontaneous intestinal perforation occur? What is the classical presentation for spontaneous intestinal perforation? first week. هو بس كده first week. Usually we see, yeah, this could be part of the differential, but it doesn't fit 100% to this baby. It occurs more in preterm babies. Usually they have some RDS, they take endosin either for IVH treatment or for prophylaxis or other NSAIDs, and it occurs at the terminal ileum, but it is in the differential diagnosis. And I see gastric ulcer. Yes, this baby had gavage feeding, and we mentioned before that the NG tube can cause gastric ulcer and can cause bleeding, profuse even, and can simulate neck and can simulate acute abdomen. This is a good choice also. Trauma, yes, especially non-accidental, if this is a child abuse, yes. Yes, endomethacin and steroids, correct. This, I forgot to mention that steroids also in addition to the NSAIDs. Drug-induced, what is drug-induced? Sometimes you think I'm sitting in your brain and you are giving me answers as if I see your thoughts. Never mind. Okay. So they started taking this baby seriously. Seriously, okay? So they did another X-ray. Oh, there was no another. This is the first X-ray. And what did they found? Can you read this for us, please? Anybody who is interested in babygram. Is this babygram normal or abnormal? And if abnormal, why? And you have to look very carefully. Look very, very carefully below the diaphragm and in the liver. Air in IVC? No, there is no air in IVC. Air in porta hepatis? It is we call it air portogram, which is air in the distribution of the portal vein. Air portogram. And there is air under the diaphragm. Free air, meaning, what does this mean? When you have air, free air in the abdomen and air portogram, what does this mean? Intestinal perforation, correct. There is something else they didn't do, I don't know why, but they should have the left lateral DQ, which will illustrate free air more easily than this AP babygram. You make the left side up of the baby, and you make the film on one side behind the baby, and the X-ray cathode on the other side, and then you take a film. The air will go by gravity up, filling all the left part of the abdomen in this area. It will be very clear. If you suspect pneumoperitoneum, you should do left lateral DQ. This is like a rule of thumb. They didn't do it, I don't know why, but they should have done that. Also, what else? We have dilated loops, and we have multiple dilated loops. And we mentioned before, when you have dilated loops, the number of dilated loops is related to the site of the pathology. The more you have dilated loops, the more you have distal problem. However, do you see any pneumatosis? واحد كاتب هينام على جنبه الشمال صح؟ لا يا حبيبي، هينام على جنبه اليمين. I said left side up. It's called left lateral DQ, or you can call it cross table. You can call it cross table lateral. Cross table lateral or left lateral DQ. And in this case, the right side above, left side below, down, and the film on the back, and X-ray cathode machine on the front. And if you need the right side up, you can do it in pneumothorax. You can do it, and you call it right lateral DQ. Or right lateral DQ, okay? Right lateral DQ. على فكرة انت ممكن تكوني انت صح. انا شكلي اتلخبطت. هو ده. This is the right side. I'm sorry. I'm sorry. Right side up زي ما حضراتكم قلتوا. left side down. I'm sorry. ليه بقى؟ لان انت هتشوف الهواء هنا في المنطقة دي عند الليفر. at the liver. Okay? I'm sorry. Right side up, left side down. This is the called left lateral DQ. حضراتكم صح وانا كنت غلطان. معلش اعذروني، انا ساعات بنسى. Okay? And if you need to do right lateral DQ, you do the other way. And usually we do the right lateral DQ if you need to look at the right pneumothorax to see how much is the pneumothorax is, what is that, because this will help you to decide how the baby is going to be distressed, if you need an immediate chest tube or not. So, or to make your life easy, you call it you call it cross table lateral. Cross table lateral. Okay, cross table lateral. حضراتكم صح، فاهمين صح، انا اسف. ماشي. ما عملوش، مش عارف ليه. بعدين عمل ايه بقى؟ طبعا this X-ray is more illustrating than the other one. Now you see air under the diaphragm. Definitely there's free air. برضو ما عملوش الكروس تيبل. وبعدين you should see dilated loops with multiple levels. There was some kind of obstruction and perforation and pneumoperitoneum. So what was the cause? Do you see the pneumatosis? دلوقتي حضرتك بتقول لو يو في سي. ده يو في سي هنا اهو. ليه لو؟ it should be at the dome of the diaphragm. الديافرام عالي شويه عشان فيه هواء، لكن هو اصلا محطوط صح. اوكي. Do you see pneumatosis? You can see pneumatosis. فين يا عم؟ فين يا دكتوره ميادة؟ Where do you see the pneumatosis? Can you just tell me which quadrant of the abdomen? Right, left, upper, lower, in the middle? Where do you see pneumatosis? Do you see pneumatosis? No, you don't see it. And the hallmark of the diagnosis of neck is pneumatosis. Is pneumatosis, period. So this is not pneumatosis. There is no pneumatosis. This is not neck. So what was the condition, which was also a rare presentation, but it raised the differential diagnosis of acute abdomen in the newborn baby. And what is the problem causing GI bleed, upper or lower? We discussed this in full details. Okay, so don't forget to do the cross table lateral if you are suspecting a pneumoperitoneum or pneumothorax. Right side up, and then pneumothorax you can do right or left depending on which side. This baby had, this is their differential. Neck, yes, they had neck on top of the list. And of course, as you mentioned, malrotation and volvulus. Yes, this is a very good possibility. Intestinal atresia and perforation, spontaneous perforation. One of you mentioned that, but you didn't comment on how, when, where. And then the actual diagnosis is acute perforated appendicitis. It is very rare, very, very rare, very uncommon, but it is there. And this is what they found. And last, the baby did very well, and they did got rid of, they sealed the perforation. And so, what are the lessons? Consider broad differential diagnosis. Neck is common, but not the sole cause of neonatal abdominal symptoms. This is like the rule, the going home lesson number 1. Number 2, radiological evidence, repeat imaging may reveal clinical findings, such as if you're suspecting something and you have an X-ray that doesn't show clearly, just wait and repeat. Early surgical consultation. You have to have your pediatric surgeon hand in hand with you from the get-go, from the first moment. They have more experience than us with surgery, with surgical problems, and they can feel it, they can smell it, and they can help us a lot. Awareness of rare entities. You have to keep this in the back of your mind. Think of common, and then less common, and then rare, and then very rare. But this is our job. You have to think broadly. Multidisciplinary approach, whatever, okay? And then we'll go to case number 3. Any questions before we go? Because the last case is also going to raise some important issues. So if you excuse me, I will keep going if you don't have any question. So this is important because this is also everyday life problem. We have a 32-year-old gravid woman, type 1 diabetes, controlled hemoglobin A1C 8.2, and celiac disease. She has severe preeclampsia. However, perinatal screening were unremarkable. Baby was delivered by C-section for the deterioration of preeclampsia, 37 weeks. So, like early term baby. Presentation of GARS 5 and 7. Physical exam, everything looks fine, except the weight this is the weight, the length, the circumference, everything looks fine, except, okay, genitourinary, stretched penile length of 2.1 centimeter is as shown in figure. This was the finding they found. So the testes bilaterally descended, most probably of normal size. Scrotum well pigmented, normal scrotal rugosity, no hypospadias, no chordate. Just the penile length was 2.1. Is this for a 37-weeker normal, below normal, above normal? Below normal. So if it is below normal, what do you call this case? You call it possible micropenis. What is your differential? And I also, and each time I ask you this question, if you have a male newborn baby and this newborn baby is having hypoglycemia and have micropenis, what is your diagnosis? Give me one diagnosis. DSD central. Diabetes simplex, dorsalis pedis central. I don't know. You're giving me a hard time with all these abbreviations. CAH, congenital adrenal hyperplasia. So you are considering this like ambiguous genitalia or isolated micropenis. What do you think? Disorder of sex development, DSD. Thank you. Okay. If you have a newborn baby, male, hypoglycemia, micropenis, you have one diagnosis, growth hormone deficiency, period. If you have a male baby, this is outside our scenario, but you have to know that. A male baby, and then boy, and mom comes to you and tells you, you know what? The urine stream for this baby is bifid. Is bifid. Is this abnormal, doctor? What are you going to answer? It's outside this case. Yes, because of there is no much time. Yes, I will say yes. This baby needs to be evaluated for posterior urethral valve. This very, very easy diagnostic issues. Like when you have a female baby with webbing of the neck and pedal edema. Neck webbing and pedal edema. It is Turner. No way. Okay. So you said this 2.1 is small. So this could be micropenis. So what are your differential? You mentioned that it could be congenital adrenal hyperplasia. It could be abnormal development of the whatever you said, something abnormal development. What else? If you have a very, if you have a choppy baby who is like maybe infant or diabetic, large baby, and when you look at the penis, you might think it's micropenis. What do we call this? It is in the differential, but it is not micropenis. What do we call this? And we see this a lot. We call it buried penis. If you go at the base of the penis and allow the penis to go out, it will show up, and you know that it is not micropenis. Brother Willie, I don't think you were. This is a good answer, Hind. Hypogonadism. Mاشي. Okay. Let us see what was their differential. And because you missed a very important differential, which is the diagnosis of this case, and you might see it. Okay, this is how the penis looked like to them initially. So the initial provider who saw this baby, the physician who saw this baby initially, said, okay, you know what? This is a micropenis. And he checked the length of the penis. And it was found to be 2.1 centimeter. And he said, okay, this is small. This is their differential. Is it really micropenis? It could be isolated growth hormone deficiency. I told you, if you have a newborn baby, male, micropenis, hypoglycemia, it's growth hormone deficiency, period. Multiple pituitary hormone deficiency. Someone of you said panhypopituitarism. Yes. Differences of sexual development. Yes, one of you mentioned that, such as partial androgen insensitivity syndrome. Yes, this is very rare, but it could be part, and it usually gives you ambiguous genitalia because there is the baby has testicles, they secrete androgens, but they don't function because there is end organ insensitivity or non-responsiveness. It could be idiopathic, buried penis, we talked about that, trap penis, I don't know what does this mean, and webbed penis. What is the webbed penis? This is the webbed penis, which gives you a false impression that the penis is short and makes you make your measurements from the long side. What the initial provider did, he measured the penis from here, from this area, because he thought this is the start of the penis. Actually, he went up a little bit higher. I'm sorry, higher. But actually, the penis starts here, maybe here. So the webbed penis is when the scrotal tissue, the root scrotal tissues, goes up, encroaches on the penis and makes like a triangular area. Makes like a triangular area. It could be acquired, it could be congenital or idiopathic. It could have no symptoms. It could affect the male sexual performance in the adulthood, which we don't care about. So when you see this, you have to be sure that you are checking the true length of the penis. And then we are going to discuss some issues related to this everyday issue, because the mom can come to you and say, okay, you know, doctor, I think my baby is abnormal. I think his penis is short. It might be buried. It might be trapped, which I don't know what it is. It could be really micropenis. And you have to start digging and looking for hormones, and it could be idiopathic. So it could be just a very simple problem, idiopathic problem, or it could be something serious. And I believe for the idiopathic, maybe the endocrinologists later on, they can use topical steroids and they can make the length of the penis become larger. But this is not our area of expertise. Okay. No. You went to Charles syndrome and Cordy and sulfaridactyl. Why this is Charge syndrome? Why is there is Cordy? We don't see Cordy here. We didn't see the Cordy, meaning that the penis will be curved, and this should be corrected. And usually it's associated with hypospadias, and this was ruled out. Okay, another important point is, do you do circumcision in the NICU? Dr. Marwa, do you do circumcision?
الصراحة لا يا
احنا
دكتور.
بس احنا بنبلغ جراحة الأطفال هما في المبنى
Unfortunately, I have to do circumcision in this country. I don't like it at all, but it's not a good procedure. It's not my favorite procedure, but I have to do it. Never mind. If you have possibility that the penis is abnormal, like Cordy, hypospadias, epispadias, short penis, ambiguous genitalia, you don't feel the testicles, whatever, don't do circumcision, okay? So what happened is, another provider who did a more careful examination and started to differentiate the true micropenis from the pseudo micropenis. And then they diagnosed the baby as primary webbed penis. Primary webbed penis. And this is okay. I need to show you what is a webbed penis, or it's called penis palmatus. It's a rare congenital condition characterized by a skin fold obscuring the penoscrotal angle, like a tint of tissue or skin fold has rugi, rises from the scrotum between the scrotum and the penis and give you a false impression that the penis is small. And then we come, I will not go into congenital malformation of the penis, which you should know, because this is important, especially if you are the one who do the the circumcision. So I will give you some hints about important issues. How to measure the length of the penis? It is called the stretched length of the penis. Okay? And you have to stretch and you measure from the base to the tip of the foreskin. And in most of the studies, I found that the mean is 3.55 for a term baby, because the preterm babies will have their own numbers. And the lower limit, the cut point, if you find it below that, it is micropenis, definitely. If it is less than 2.13 for a term baby, appropriate for gestational age, okay? And the circumference also is important. And the standard, and the mean, or the upper, sorry, the cut-off upper limit is 4.98. 4.98. Okay, you have to check it also if you suspect something wrong. And oh, sorry. This was the cut point for the length. If the penis is more than 4.98, it is large penis. I don't know what does this mean, if this abnormal or that, I have no clue. And the circumference, this is the circumference, which is 3.96. Okay, and then comes another issue, and this is like the birth weight and approximate measures of the body and of the penis length, if you are having a preterm baby or tiny baby or whatever. And another issue which is related to this issue is if you suspect something issue with the some issues with the penis, and you need to complete your genital exam of the baby, sometimes you need to decide the size of the testicles. Number one, is there in the scrotum, if they are in the scrotum or not? If not, are they like rabbit testicles? They go up and down, or they are up in the abdomen? And then is it one side or both sides? And after that, you have, in some conditions, you need to decide if the size of the testicles is normal. For example, if the baby in utero or after delivery had torsion of the testicles, which can cause ischemia and atrophy of the testes. So you might need to measure the size. This is an example. So what they do is they do what they use is called the wooden radar or kilometer. This is done for adults, for children, for baby, and they have different sizes for different ages. What you do is that this is the measurement, and you place it very close to the testicle. You are trying to see the size, and then you have each one has each. If you go to the table, you will know what number one means, what number two, whatever. And this is adult levels, and this is, they call it the wooden radar or kilometer. I think I'm going to stop here. And if you have any question, today we had close to 2.5 hours. I'm sorry, I've not been with you for a long time. Maybe this will do some compensation. Do you have any question, any comments?
شكرا جزيلا لحضرتك يا دكتور. شكرا.
I hope today talk was productive and helpful. We ran through a lot of issues, a lot of problems. Some of them are common, some of them are very, very rare. But this is medicine. You have to deal with all aspects. Who is going to present next time?
دكتورة هالة، كالسيوم فوسفورس ميتابوليزم normal and
Abnormal, term and preterm, fetal, intrauterine and postpartum. This is a very wide and it's a very big article and topic.
calcium and phosphorus metabolism يا دكتور. calcium and phosphorus
Yeah, but she has to deal with the normal calcium and phosphorus homeostasis in utero, its relation to maternal status, and then after birth, term, preterm, healthy, and sick babies. And there is a lot of differential diagnosis, and there is a very good topic under that, which is the metabolic bone disease of the preterm babies. She should refer to that. And the problem is that for the next 2 weeks, I'm very busy. I will be outside, out of town for 2 weeks. I'm not sure how much I'm going to communicate with